Physio coaching comprises hurt versus harm and exposure therapy. 3 controversies. The first controversy is that all physio coaching is hurt versus harm and exposure therapy. The second controversy is hurt versus harm itself. And the third controversy is physios using exposure therapy. Stay to the end and we'll talk about that first controversy, but we're going to start with the second one, hurt versus harm. We'll start with the second controversy, hurt versus harm. I have a case study and we'll talk about that. Hurt versus harm is the cornerstone of physio patient education. Yes, there's some basic science education about anatomy and healing, but that's not specific or foundational to physiotherapy. Hurt versus harm is foundational to physiotherapy coaching and is well explained elsewhere. In brief, hurt means that something makes you feel pain or discomfort, but it doesn't cause serious damage. For example, you fall down, you scrape your knee, that would hurt, but that wouldn't really cause real damage. Harm, on the other hand, means that something actually is damaged or injured you in a more serious way. Harm can be a physical injury, like breaking a bone, or it can be emotional, like somebody being really mean to you or making you feel very sad. The key difference is that hurt is something that might make you feel bad for a little while, but it doesn't cause any lasting damage. Harm is something that can actually hurt you or cause problems in the long term. Since this is a controversial section, I would also add that this is similar to the modern debate about hate speech versus free speech. Defining hate speech is difficult or impossible. But the controversy here for hurt versus harm in physiotherapy is figuring out the difference. Patients complain about problems and pain. As physios, we make a judgment about whether this is really a significant issue or not. We look for red flags. Cancer and infections are the two big worrisome culprits here. As physiotherapists, we make that judgment, and if there's no clear red flags, the typical advice is to tell people to keep moving, that they're fine, to work through the pain. But there's some subtlety here. This is the controversial point about hurt versus harm. We really don't know who is going to be that rare patient who has something catastrophic. We need to treat every patient as if they are that patient. My typical patient advice about pain-free exercise use and don't make things worse still applies. I started to wonder about hurt versus harm and where were the limits years ago. I was working in an acute care hospital. I wrote a review article about the use of exercise in acute care. This is my hurt versus harm case study. An 82-year-old lady known to our outpatient physio clinic for various aches and pains, including chronic low back pain and an old lumbar surgery. She frequently saw a chiropractor and massage therapist independent of our practice. She was an independent ambulator, community distances, intermittently using a cane. She lived alone. She did her own shopping. She presents to physio with a referral from her family doctor for a worsening of low back pain with no trauma. She gives the onset as rolling over in bed. Apparently, imaging was unremarkable. She had 6 weeks of a rapid decline in mobility. She went from using a cane to a rollator walker, and then she was home with home care. And then shortly after that, she was in home care hospice. From a physio perspective, treating this patient was based entirely on hurt versus harm. Her treatment was really a case of coping with whatever she was giving you on that particular day. That's my advice about pain-free exercise use and don't make things worse. The other thing you'll notice about my story is a lack of medical details. As a physio, you probably never get the medical details about your patient. Doctors are too busy. They'll just write something on a script, something generic like difficulty walking or low back pain. The patient may or may not know. Sometimes doctors do tell the patients and sometimes they don't. We always have incomplete information, but we always have to do the best with what we have. So when you teach patients about hurt versus harm, don't be a jerk. They are in pain and they're struggling, and we really don't know what's going on medically. This is the controversy and the reality of hurt versus harm. We have to keep this in mind. The third controversy from my title is that physios use exposure therapy. There's some good YouTube resources about exposure therapy. Exposure therapy is a teaching method in psychology. The therapist determines your problem and then lets you safely and in a controlled way, lets you voluntarily approach your problem a little bit at a time. So by letting you voluntarily approach your problem a little by little, you get a little bit more capable of tackling your problem. This is one way to overcome a fear, like a fear of dogs or a fear of heights, or the kinesiophobia with chronic pain. The controversy for me is that this is a technique borrowed from psychologists. I have no training in psychology, but when I heard about exposure therapy, I realized this is what we do as therapists, as physiotherapists, all the time. For example, how do you get a patient from non-weight bearing to weight bearing as tolerated? This is how you get a wrist fracture patient to reintegrate their hand back into their body schema after a cast. This is like getting a low back patient through their kinesiophobia when they have back pain. So my point here is that while we are not trained as psychologists, we actually do this psychological therapy with our patients. It behooves us to know about these techniques and incorporate them into our therapy. So use YouTube or read books. I like this guy. We need to know about these treatments as much as we can. The first controversy, the biggest controversy here, though, is that physio-patient education is really just those two things. It's hurt versus harm and exposure therapy. It's been my experience that I spend most of my time teaching patients about hurt versus harm and exposure therapy. That's my controversial statement here. Agree with it or disagree. I have one more patient example. This is a 54-year-old office worker with a running hobby. Patient was referred from a family doctor with foot pain. Patient reports he banged his big toe. Doctor thought it was unremarkable, no imaging, no antibiotics. Referred the patient to physio with difficulty walking. On examination, there was good range of motion, good strength. One big toe was tender, but not red, not swollen. Gait without device was mildly antalgic, and the patient said he could not run because of the pain. We tried a rigid bottom shoe, and his gait then looked normal. So I told him to wear the rigid bottom shoe all the time, resume pain-free activities, except running. We added strength and balance exercises, sit to stand, progressing to single leg unsupported, standing balance with perturbations, mini lunges, walking balance, and see my book for progressions of these exercises. This is a good example of educating the patient about hurt versus harm and gradual exposure. Don't make things worse and do pain-free exercises. Every couple of weeks, he'd try to run but have to stop due to the toe pain. A couple months later, patient comes back, still wearing the rigid shoe, not running, not really progressing, and he said he was doing the exercises. So when I looked at the big toe again, it didn't look bad. There was no redness, no swelling, mild tenderness about the nail, good range of motion, good strength, normal gait wearing a rigid shoe. I wondered if it wasn't a physio problem after all. I suspected an ingrown toenail. So I recommended he get a pedicure, preferably somebody with experience, and then come back when his toe was feeling better. About a month later, he comes back looking for advice about getting back into running, now that the toe pain had gone away. So there were two issues here. One was the rigid shoe going to a regular running shoe, and then the other one was the reintroduction of running itself. For the shoes, I had him wear the regular shoe starting an hour a day, do that for a week, and then 2 hours for the next week, and then 3 hours, and so on. Not running, just daily pain-free activities. So it took him about 3 months to get back to wearing a regular shoe, even being barefoot at home all the time without any toe pain. To get back to running, I had him gradually reintroduce it again using more hurt versus harm and gradual exposure education. He said he could do 10 minutes of treadmill walking pain-free. So I had him do 9 minutes of treadmill walking and 1 minute of jogging. And do that for a week, and then the next week do 2 minutes of jogging, and then 3 minutes of jogging, and so on. As long as it was pain-free, we could progress. There were some minor setbacks and with some aches and pains, and it did take several weeks before he progressed to running for the entire 10-minute period. In this case, the exercises were supplementary. Like I said, range of motion and strength were good, and the patient needed education about hurt versus harm and exposure therapy. Both of these case studies exemplify the importance of my pain-free exercise use and don't make it worse approach. I know I've introduced some controversial ideas here, but what would you have done differently with these patients? Let me know in the comments below. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Watch a different video here or subscribe to stay informed. Thank you.